Dr. Batiste, welcome. Thanks for spending the time with us tonight.
Appreciate you having me. And what an incredible story. I love your story for
You
many
know,
reasons.
one of the most amazing things about the story before we get to the official interview was that my cardiologist, who I have the absolute utmost respect for, he might even be watching tonight, didn't know anything about plant-based nutrition. But I think what happened as the process of me getting healthier, of me being able to reverse the stage one heart disease, to be able to recover from the stroke, is that he gets it now. And I think that's one of the things that we all in this community want to do more than anything else, is to make sure people understand that it's not just a story, but it's a lot of science rooted in how we're eating and how we're living our lives.
Well, I think what's even more important about that is the fact that we all can learn from each other. It really doesn't matter about our degrees, our titles, the schooling. There is something to be gleaned from every single person on the face of this earth. And so I think it speaks volumes of your provider that he or she would be willing to learn from your experience and incorporate it. One of the things that oftentimes I'll say inside of our slave food conversations, and my colleague said this first, is that, resources go where value is placed. And so many times people will say, well, why don't doctors know about nutrition? Well, resources go where value is placed. And when you look at that conceptually, inside medical school, the primary goal of every medical student is to pass the USMLE, the licensing exam, part 1 and part 2. Now, the exam doesn't include anything on nutrition. So therefore, resources do not go there because there's no value that's placed. Then you graduate medical school. And once again, the goal of every intern and resident and fellow is to pass their board certification, because every good abiding American wants to go to a board certified physician. But the boards don't include anything about nutrition or lifestyle. So once again, resources go where value is placed, and that leads you away from lifestyle. Then you enter into practice. And once again, you have to bill for your time, bill for the diagnoses, bill for the procedures. And there's historically is minimal billing for lifestyle. So then, therefore, once again, resources go where value is placed, and physicians garner their time towards pills, procedures, in other words, and it never circles back around to the primary driving cure or treatment, which is lifestyle in terms of chronic disease burden.
So does this really speak volumes about a value-based system in terms of how doctors should get compensated?
Absolutely. Absolutely. I mean, I think it even speaks eons back further than that into the way in which our educational system has dispelled and put aside some of the things that are lifestyle derived. And so these things haven't been taught. These things haven't been shown. And so as a result, you're right. There's been a change in the value base.
So what ultimately led you to change your relationship with food, and why plant-based? I mean, did you have an epiphany? Was it a process for you?
It was a process. It was a process. There wasn't just like all of a sudden I woke up and I had this vision and that was it. I'll tell you in all honesty, one of my colleagues early on in my career, he remembered me from that time, and he said, I remember Batiste. Batiste was about procedures, more procedures, more procedures, and that is the way to treat heart disease. And another colleague friend of mine started laughing. He was like, no, that's not him anymore. And so my transition really started where I had patients asking me, hey doc, what should I eat? And I remember telling them just these off the cuff sort of answers. Just do well for 7 days. That's all you have to do. I said, you don't even love your job for, 7 out of 7 days or this, that, and the other. I give all these little statements without any factual basis. And one day I heard myself speaking and I said, I need to do better than this. So I went of all places. I didn't go to PubMed. I didn't go to the library in the medical school. I went to Barnes and Nobles. I just started rummaging through books, and I looked for books that have physicians' names on it. And I started looking, but I still didn't make any major changes. And it wasn't really truly until after I watched my dad succumb to the ill effects of diabetes, which is really the identical twin of heart disease because it just ravages the body inside out. And after coming out of the darkness of that experience, what I realized in that moment was the fact that I needed to figure out what I had missed, what the medications didn't do, what the procedures didn't do. And I started really reading. And I started reading. This was at the beginning of YouTube and these things like that. And I started going through, And I was just convinced by the power, the information from the likes of Dean Ornish and Esselstyn, and even going back before that to Nathan Pritikin, looking at the actual research and going then into PubMed, which is a National Library of Medicine division where you can do researching on papers. And I really saw that, guess what? This disease, vascular disease, heart disease, could be stalled. And in some instances, the perfusion reversed or improved. And that's all I needed to hear at that point in time.
Isn't stroke and diabetes and cardiovascular all the same disease?
It is. It is. I mean, stroke and heart disease, it's just a matter of location. You know, out here in California, I'm in California. And so we have these long freeways or highways, we call it. And you will be on the same road and all of a sudden you transition and the road is called something different. You'll transition it's the Artesia freeway to 91 to the 215 or vice versa. You have all these variances just upon the road traveled. And so that's the same thing with strokes. Strokes are just located inside the brain, but it's the same vasculature that affects the heart, the same vasculature that affects leads to impotence, the same vasculature that leads to peripheral vascular disease and cramping in the thighs and legs.
You mentioned your dad. Did he have diabetes throughout your life? Was that something that you were afraid you would actually succumb to?
I don't know that I was afraid. I just kind of saw it as this is the natural course of things. That I grew up with my dad. There were needles there and so forth. There was insulin around, and this is how life was. It was just one of those things. I didn't really think twice that it didn't have to be that way growing up. I didn't think twice about the fact that watching my grandfather with Alzheimer's, that maybe it didn't have to be that way. I assumed that this was a course of life that we all were succumbed to.
So what happened when you did make the change, and what did you see right away in your cardiology patients? Was it immediate?
Well, yeah, I'll tell you, it was meant to be. I believe in the higher power. I mean, I don't believe I'm here by chance or by anything of that sort. And I'll be honest, I was afraid. I mean, if you know this, I have a distinctive appearance to myself. No, not in that I have fluffy hair, nice hair like you do, but a distinctive tan. And so I'm African American, if you didn't know. And so there's not a lot of African American cardiologists around the nation, and specifically the area that I practice in. I'll be honest, I was scared of being that guy. Of being a guy who was different than everyone else, that I was recommending something different than everyone else. I had gone through training to be an interventional cardiologist, and to start to recommend things that were different, it actually scared me. And it came to a certain point that I just said, you know what? I just have to do it. And I'll tell you, this is why I say it was meant to be. The first 3 patients I got, one came to see me because of the fact that my colleague said, well, I think you need a complex stent. Go see Columbus. Another one came just to see me with crushing chest discomfort. And another one, I didn't have any eloquent words. Wasn't extremely knowledgeable about the science. I just was learning the process and really understanding things. And all I did was write down 3 books for them. Just 3 books. And I said, and I validated the importance of embracing lifestyle, of transitioning their diet from where they were at to something different. And I'll tell you, all 3 patients came back to see me with improved symptoms. Even my colleague said, he was like, man, Columbus, I'm not sure what's up with what you're telling people about diet, but it obviously works. And so I knew in that instance that this was something I had to do, and it wasn't about me. I had to get out of my own way. And I needed to start just conveying information to people, and hopefully the message would be received by those who listened.
You mentioned health disparities, so it's a good opportunity to jump a little bit further in there. Health disparities, health equity are some of the hottest topics today. I think about myself and what happened to me, that I'm fortunate of who I was, my color, where I live. I might not have had that same opportunity to be taken care of if I was in a neighborhood that didn't have access to good hospitals. So what are you most passionate about related to the health determinants and health disparities, and what should our audience know about this?
Well, I'm most passionate about eliminating it. And I'll tell you, I saw it for the first time in my life up close and personal. So coming out of COVID, out of the pandemic, we knew that we were seeing increased amounts of heart attacks, of thrombosis, of strokes, of pulmonary embolus, of inflammation of the heart, and so forth. We saw these things starting to take hold across the medical literature, and we were seeing it clinically. And I'll never forget, and I've had this, I was allowed to convey this information, but my wife, all of a sudden she tells me, hey, you know what? She calls me, and she had taken my daughter to a birthday party. We were at the end of the pandemic and so forth. And she says, hey, I was having chest pain. I think I'm having a heart attack. I said, what are you talking about? First of all, my wife minimizes everything. So I'm like, are you joking? What's going on? No. Well, I took the dog for a walk and I had some chest pain when I was out walking. And she had just recovered from COVID. And I said, okay. And she said, I took 2 aspirin. I said, okay. And then she said she proceeded to take my daughter, but felt so much discomfort in her chest that she didn't want to walk in with my daughter into the restaurant. And I said, okay, I'll be right there. I said, but you need to call 911. And called a friend of mine who was close by, a physician out that way, called 911. By the time I got there, the ambulance services were there, but they didn't want to take her. They said, well, I think she's okay, but she's still having discomfort. I said, I'll take her myself then. I drove her to a hospital where I had worked before, where I've done procedures, where I've opened up arteries, that I've taken care of patients with heart attacks. I didn't have my scrubs on. I didn't have a lab jacket on. I didn't have my badge. We waited in line like anyone else, where we know that the priority should be for patients who are potentially at risk for a heart attack should be taken immediately. The symptoms, in my words, were minimized by the nurse who was checking me in, who was not my color or hue or complexion. My wife goes to the back. I'm not allowed in, which I understand the protocol. She was not. I called her and she said, oh, I'm just waiting out here. I said, have they done an EKG? Are you back under monitoring? Long story short, nothing had been done. Her symptoms were minimized. She's an African-American woman, and I saw firsthand, with full knowledge and scope, about the way in which someone should be triaged and treated, coming in with symptoms suggestive of a heart attack, and someone who has not utilized the system before. I saw firsthand disparities, which means a difference in care. You know, as I explore through literature, we understand that this is pervasive through gender, males versus females. We see it based upon racial groups. There's a racial divide in terms of the preponderance of disease, but also not just that, the treatment. So what that means is that if you have 2 individuals who go into the hospital at the same precise time, who is more likely to receive appropriate care in the setting of an acute heart attack or other therapies? It's not going to be the person of color. Then what's so interesting is New England Journal of Medicine did a study. This is now probably about 30 years ago, and they brought in a group of actors, gave them the same verbiage, and they had different physicians of varying different genders and backgrounds all interview the patients. And what was so uncomfortable and disappointing was that there was a difference in terms of the assessment of what the patient had based on their race and their gender. You were less likely to receive care if you were a female and you were of African descent when given the same precise scripting, the same lab values in terms of this with physicians. And so that's a disparity. That's a difference in care.
How do we start to change that? I mean, what has to happen to make that go? And no, it's obviously societal, but at a local level or at a hospital level, what can be done?
I think it's discussions, conversations just like this, recognizing that we all have biases. You know, I have biases too as well. I've given examples before of seeing someone of Caucasian descent who was disheveled, and I thought, well, they'll never listen to me. They smelled of cigarette smoke. There was dirt under their fingernails. And I minimized my care delivery. I didn't tell them about lifestyle on first glance. I didn't tell them about the various options. I was very direct because I made assumptions. I had a bias. So biases are extensive. They're a subconscious occurrence based upon societal cues that we've developed over the years. And so we have to recognize that they exist in all of us. I'm not excluded because I'm African American. Another person isn't excluded because they're female. And so these are things that we have to first identify and begin to have conversations about them.
You know, nobody's unbiased, and we all have the biases of our families, the things we heard years and years that we don't believe in, but it's still back there.
Yeah.
And it's really tough to get that and have that conversation is a tough thing. In healthcare in particular, though, so what are 1 or 2 things that are needed to happen right now to start to fix that? I mean, is there anything that can be done? Anything that Planned Parenthood can do to help that conversation go further, other than, having conversations like this, obviously.
Yeah. Well, I think one of the things that we have to do is we have to get into the community. And one, we have to educate the community to empower them to enact change. Is one thing that we can do for the community so that you can become a self-advocate. So if I understand that, listen, my dad had diabetes, I'm at risk for diabetes. Yes, I would like to have an A1C because I'm at the appropriate age where I should. I interviewed someone on the Slave Food podcast recently, and they're identical twin brothers inside of a different country of Bermuda that's faced with very similar type challenges we are here. The brother was diagnosed with prostate cancer. The other identical twin brother started having symptoms of an enlarged prostate, but his provider, who was of different gender and different hue, didn't even test him for a PSA or do a digital rectal exam. Amazing,
But
right? And so
practice.
it is, absolutely it is. But it's also malpractice that if I know that someone lives in an increased risk inside of where they live, that their nutrition is poor, that their blood pressure is high, that they're reporting symptoms, and I don't follow through and do certain tests, that's also malpractice. If I don't go ahead and implement certain strategies, that's malpractice. I believe as well, informed consent means I also have to let patients know about, yes, TPA, when appropriate, yes, stents and surgery, but yes, lifestyle. Now, that doesn't pertain inside of an emergent situation, but in stable situations and post-care from those acute events, yes, it's important that I let people know about the importance and the power of lifestyle. There were studies that were done showing that exercise has better outcomes than, guess what? Placing stents. That your functional capacity is way better than what your heart function is, meaning how much activity you can do. So we understand the power that exists in sort of activity and exercise and nutrition. And we as a group of healthcare providers we must do a better job if we have any chance of withstanding this onslaught of chronic disease.
It's so important to understand this before you get affected by it. You mentioned TPA, and it just triggered a memory in my mind that when we got to the emergency room, they mentioned the TPA. They said, look, got a 40% chance that this is going to take care of making sure there's no other clots that happen in your body. And they said it's a 50% chance that there'll be like a placebo. Now, I still have my faculties with me, and I know math. I go, there's this 10% missing. What's up, doc? And he said, you might hemorrhage and die. And, there's sort of questions that all of a sudden you go, if I had known about lifestyle before, I wouldn't be in this situation right now. And I think we need to, as much as possible, just let people know that's really where you want them to be.
Yeah. And if I'm truthful, there's no 100% guarantee in this life.
Yeah.
So you have patients who will do everything perceivably that's correct and can still end up in a situation where they're in need of care. And I think that's the value of being able to tap into care when you need it, but not to abuse the care because you abuse lifestyle, that you want to marry the two together.
So one other thing about health disparities, how does stress play into it? And is that something that is very focused on an African-American community as opposed to another community? Expand.
No, that's great. So we know that there's something called socioeconomic status. And so we understand there's a huge financial disparity and divide inside this country of those the haves and the have-nots. And there's a multitude of studies that have shown that the stressors of socioeconomic status of a lower socioeconomic group tend and historically do poorer than groups with a higher socioeconomic status. And so this becomes important. So when you add that to racial disparities and gender disparities and sexual identity disparities that begin happening, you have this cascade that triggers in the amygdala and begins this process of stress hormones that begin to cascade and peruse throughout the body, activating the bone marrow and leading to inflammation and leading to destabilization of the coronary plaques that lead to what? Heart attacks, strokes, and events. That this cascade of stress hormones that percolates, it impacts your sleep. Now it worsens your sleep, which drives up the stress hormones further. That then drives this cascade of preparing you for fighting or for fleeing, right? And that also produces what? High blood pressure, produces diabetic state. And so it becomes a vicious cascade that's intertwined. Now we light the match by, in these communities that have lower socioeconomic status, we fill them up with food deserts and food swamps and poor nutrition foods of what I characterize as nutritional stress, that now it becomes combustible. And we see this explosion of disease and we wonder why. Why are there marked stark disparities during COVID in certain communities? Why is it that people are struggling? Well, because this has been the case for many, many, many decades, if not centuries, that have gone by in the past.
Amazing. You've used the acronym SELFISH before. Want to elaborate on that and how that applies to the conversation we're having tonight?
Yeah, it's a cure. I mean, in all honesty, we look at selfish in a negative connotation oftentimes, and it's something that just struck hold of me probably several years ago. I'm trying to put pen to paper now at this point. But oftentimes inside this idea of lifestyle, we focus on nutrition, rightfully so. And nutrition still is the central core of the message of selfish. But selfish is an acronym that starts with spiritual. Doesn't necessarily mean religious. It could mean becoming in tune with nature. It could mean deep breathing. It means, yes, for those who actively are meditating and praying, we do see that there is an increase or a decrease inside the stress hormone cascade and improved outcomes. And these pertain to cardiovascular events, lower rates of diabetes, improved mentation, ability to focus in school is the S. The E for exercise or activity. I always tell people it doesn't have to be CrossFit. Doesn't have to be Taibo, for those of you old enough to remember Taibo. Doesn't have to be Peloton, right? Or Jane Fonda Fitness, aerobics. It can be simply just walking up and down the stairs, parking further away, taking the stairs just a little bit more, that you engage something called non-exercise activity thermogenesis, getting neat with it, that it helps lower your blood sugars too as well by walking 2 minutes after you eat, just 2 minutes. Powerful that's there. The L stands for love. We oftentimes think of love as a noun, but love is an action word. Anyone who's loved in their life, whether it's a mother and a child, a father and a child, or a spouse and their significant other, it requires what? Forgiveness. It requires gratitude. That you have to do these things as an expression of love. And studies have shown that when you begin to engage in forgiveness and you engage in gratitude, that all of a sudden it transforms your body. It improves the perfusion to your heart muscles. Some studies have shown it relaxes your blood vessels. Not to mention the oxytocin component, which is the antithesis of the stress hormone cascade. It's a tend and befriend, activating the parasympathetic tone that can help ameliorate many of the adverse events that happen. That's the L. The F is food, real food, whole food, plant-rich food, food that's from the earth predominantly, food that's less touched by man, food that you all believe in, that you talk about on a regular basis. The I stands for intimacy of relationships, that all of us, if we think for a second, really lost this during the pandemic. That human interaction, that sense of loneliness that some researchers have equated to like the same as smoking 15 cigarettes a day. That loneliness is pervasive. Even when you're around someone, you can feel alone. So intimacy becomes important. This can take the place of pets. So that's where animal rights become so important. And we see this. As I always say, my mother's favorite child is not any of her 5 kids. It's her dog, Precious, who's been there through thick and thin. When my dad passed, when she's in pain, and other times, and she's laying by her right now, I imagine. The S stands for sleep, something we should spend at least a third of our lives doing, but many of us, we minimize sleep to get things done, thinking that we're somewhat more productive when studies have shown we're walking around in a zombie state, almost inebriated. And that it's very comparable to alcohol toxicity, the way that many of us walk around in this state. Leading to heart disease and so forth. And the last is H, the humor of life. I love telling this one small study that was done, and what they did was they took a group of individuals who'd suffered heart attacks, and they said, we recognize, similar to like Ornish's program, that cardiac rehab is extremely beneficial, of exercise, stopping smoking, and adherence to your medications while you optimize your nutrition. But what they did was they added a secret sauce to one group. They said, we're going to introduce the humor factor. To one group, all I want you to do is watch your favorite movie or favorite sitcom for 1 hour. That's it, a half hour to an hour. And what they found was amazing, that in the group that watched and engaged in the humor, that started doing that they had less readmissions to the hospital, less recurrent heart attacks, that there was a statistically significant difference just by incorporating humor, that laughter is indeed medicine. So when we talk about selfish, You get selfish not so you can live a life selfishly, but so you can live a life selflessly, that you can live a life of purpose, that you can be selfless in your community and re-engage and narrow these disparities and help others around you. And that is the sole goal and purpose of getting selfish.
Amazing. We have time for one more quick question, and that is one we're asking every one of our speakers tonight. And that's, what is one thing that you do to keep a sense of positivity and purpose in today's challenging world?
I'll be honest, it's giving back. It's taking time to really meet people where they're at. So whether or not it's working through my nonprofit inside the community with barbershop initiatives or giving lectures, I'll be honest, when you give, you receive far more than you give. Far more. Long day yesterday, and someone called me up, young, 48, massive chest discomfort, found to have multiple blockages, and they were able to reach me through my sister. And so I called them after a long day of work at 9 o'clock at night. I was tired. I was hungry. Sometimes the plant-based food, it kind of dissipates in your system. You need to kind of recharge a little bit. But I'll tell you, after I spoke with them and their level of gratitude to me, I felt more gratitude to them that they had recharged my soul and my being and my purpose. That's what's important.
Beautiful. Dr. Columbus Batiste, you are one amazing individual, and we are so appreciative you took the time out tonight to join us. Thank you so much.
Appreciate you. Thank you.